You want to unmute everyone. Unmute. Can we just make sure that the mics are mute, please? Because I think there still might be some mics that are not mute, but they should be mute shortly before we start, please. There we go. Okay. So I think, can I just get someone to just make sure that you can hear me, just to send me a quick message in the chat to make sure this is all working? Is that going to be possible if somebody can just quickly send a message just to confirm that you can all hear me? Anybody on the chat? Perfect. Okay, we've got a response. Yes, working great. Thank you. Okay, brilliant. Fantastic. Apologies for the initial setup. So let's quickly get started. I want to firstly start off by thanking God for giving me this opportunity to be here today. And quick one, can I just confirm that you can definitely see this screen? Because in the past, I've had kind of like issues with seeing the screen. Just before I start and give the go ahead, just anyone just let me know that you can definitely see the presentation. Yes, clear, fantastic. Okay, so now initially I want to start off by thanking God for giving me this opportunity. And I also want to start off by thanking my family for giving me this chance to be able to express myself. And most importantly, my two brothers, Wasim and Adnan. And a special shout out to the chemist and druggist Eliza, who's given me this chance to be able to continually grow, express myself, and had a huge influence in my life in terms of, you know, she was amazing in spreading that we were one of the first pharmacies to be able to set up this service. And Sadiqur and Tohidul, two brothers who have allowed this service and this opportunity for us all to learn today to go on. So special thanks to everyone who's been involved in this and setting this up. And everyone that's here today, because in all honesty, it's a huge privilege to be here, because what we've actually done today is actually spent the most precious asset that we have, that's our time. And again, I cannot thank you enough for giving me this opportunity. And thank you for this. Just for those who are unable to attend, because do go on to the YouTube live link, it's available there as well. And before we get into this, let's quickly have a look at the community pharmacist contractual service. Now, for those of you who are not aware or haven't had a chance to go back and look into policy, I would really recommend that you go and have a read of and I'll be mentioning it today, of the Now or Never community pharmacist post that was done by the RPS. It was called Now or Never, Shaping Pharmacy for the Future. So that's going to be something really important. And it basically briefly made mention of pharmacists ensuring that they're able to use their clinical skills in order to align themselves and in sync with themselves with the vision of the NHS. So for me, honestly speaking, it's not much of a surprise that this service has come about. And neither have the funding cuts been a surprise as well. And we'll be discussing that further. So just keep that in mind in terms of moving forward. So the plan today is pretty straightforward. What I actually would like to do is to really start off by aligning our expectations. It's going to be really important to make sure that my expectation of the webinar and your expectation of the webinar is all in sync. That's going to be very important. This 1 hour webinar would also be touching on the learning outcomes and what you can expect to learn from this webinar. We're going to be talking about my journey because it will really put into perspective of how policy works, how this service that's been rolled out for pharmacists, where the writing was pretty much on the wall back in 2013. And we're also going to be touching on a topic that's very dear to my heart, and that is anatomy, a bit about physiology and history taking. And any clinician that's involved in prescribing or involved in making a diagnosis, even if it's as simple as a cough that you might see over the counter, you need to get to grips with your history taking, and you need to have an understanding of your clinical skills. Special thanks to Dr. Amir, who is here today and is one of the clinicians at Medland. So thank you for being here, Doctor, and being able to support us. So, hopefully if he is around for the question and answers, we can hopefully pick his brain and get some information and some ideas of and his thoughts. So I'm just going to quickly have a look at the chat, and there might be, seems to be okay. Seems to be an issue with the mobile app for some of the students. Not much that I'm able to help you with that at the moment. So what are my expectations from this webinar? Well, this is an introduction into the different clinical topics that we're going to be discussing. We have to appreciate that within 1 hour, it's virtually impossible for me to cover everything on history taking, everything on anatomy or physiology. It's very difficult to do that. What I want to do today is to equip you with basic skills. What's going to be important is for you to ensure that you're able to learn some skills and put them into practice. That's going to be really, really important, how you continually learn and develop your skills. This is not a lecture on the community pharmacist contractual service. If you'd like more information on that, get in touch with me. I'm more than happy to go through it with you, but it's not an information on that. For some reason, we're having all this drawing appearing, which I'm not sure where that's actually coming from, which is really bizarre, where we're getting this drawing from. So I'm not sure where that's actually coming from. So I do apologize from that. And more importantly, it is not a substitute for your learning and dedication, the hard work that you have to put in. So let's move on to the next slide. So what are my aims? Well, I want to share my experience with you. I want to explain to you why I decided to upskill. I want to explain to you the importance of continually learning and also humbling yourself and accepting that you're a student of medicine. It's something that does come with time. It's not something that you'll be able to develop immediately, but you need to be patient and develop the skills. And more importantly, I love to test myself. I love stepping out of my comfort zone and challenging myself. And that is something that I would suggest within a controlled environment that we all should be doing. It's really important to continually challenge yourself and to step out of your comfort zone. So that's going to be something that I want to get out from here. The structure of the webinar. Initially, we're going to have a discussion on my journey. So we'll be talking about policy and how the policy of pharmacy has changed. We're also going to be looking at why is anatomy so important? That's going to be part 2. And why do I keep talking about the importance of making sure you have a good understanding of anatomy? We're going to be looking at the anatomy of the ear and throat. I intend to cover the nose next week. We're also going to be looking at next week and what the plan for next week is. And history taking and how we're going to use earache as an example and using that as a case study. So part 1 is my journey. Now, what I want to address is these 4 basic areas. Why did I decide to do non-medical prescribing? What was it about policy that made me want to go and develop my prescribing skills? Now, before I started to focus on my clinical skills, I was, a contractor, and why I decided to redefine my business model. But also at the benefits of upskilling and the difficulties that you may have with upskilling, and how I bridge the gap between theory that you learn in a textbook and the practical aspect. So that's what we're going to address through my journey. So I qualified as a pharmacist in 2010. I did my pre-reg year with Boots, with the will of God. And it was in 2012, with the help of my siblings, that I set up my first pharmacy business. It was a 100-hour pharmacy. So anybody who's involved in a 100-hour pharmacy will be aware that it's really difficult to manage that business, and you have to do a lot of hours and work extremely hard. And in all honesty, I wasn't too concerned what was happening around me at the time. The most important thing for me at the time was really focusing on making sure that we were able to dispense and able to raise our prescription game. And this document, you need to write this down. It was a document that was published and commissioned by the Royal Pharmaceutical Society of Great Britain, and it was, or the RPS, sorry, at the time. And it's called now or never, shaping pharmacy for the future. This document for me now is like a crystal ball. It spoke about everything that has happened in the NHS and what was going to happen that's happened now. It spoke about funding cuts. It spoke about pharmacists taking on a clinical role. It spoke about how the role of the pharmacist could be marginalized if we don't upskill ourselves. It spoke about how since the 1970s, we've been talking about how great pharmacy is and what pharmacy can do, but we've not been able to effectively demonstrate that to those who make policy. And that's really important to understand how policy happens and being able to influence those who make policy. And what it said was that pharmacists need to develop their clinical skills. You need to develop your clinical skills. You need to be aware of policy and what's happening around you. It spoke about funding cuts will happen to pharmacy. This is in 2013, guys. 2 years before the funding cuts, it absolutely made it clear that you're going to have funding cuts. It spoke about how technology and how a commission that was done in 2001 made it very clear that the dispensing side of things could be automated. So, honestly speaking, I had read the document. It also made mention of making sure that you're innovative, making sure that you don't wait for the NHS for solutions, that you go on and develop your ideas and you start to sync yourself with the NHS. Otherwise, funding cuts will happen. And what did happen in 2015? On the 17th of December in 2015, we had a letter that was written to Sue Sharp. For those of you who don't know who Sue Sharp is or was, she was the chief executive of the PSNC. And she actually was involved in making sure that pharmacy was able to negotiate appropriately with the contract, but the government was very clear that we're going to be making funding cuts. And you can imagine as a business owner how that felt at the time. We were working day and night to get this set up, and then at the blink of an eye, we had funding cuts. So honestly, at that time, I was doing my master's in business, an MBA, and I really felt, I won't go as far as saying stupid, but I really felt upset that, I'm someone who's smart, I'm someone who's in business. How could I not know what was happening around me? And how did these funding cuts happen? Because things don't just happen. Things don't just happen. There's a process in place. And it made me remember that document that I read 2 years ago, that funding cuts were going to happen. So I then started to think, okay, who is my customer? If my customer is only my patients, then why did the funding cuts happen? So I realized that I've got two customers here. I've got the NHS and I've got my patients. So I needed to find out, was I missing a trick? So I went back and started to read international policy. I started to read public health policy. I started to find out what was happening on an international level with health policy. I started to research what was happening on a European level, a national level, and a local level. And what I found was that throughout the global economy, there is a healthcare crisis. There's a shortage of doctors, shortage of nurses. There's a rise in non-communicable diseases like diabetes, obesity, cardiovascular disease. And everyone is looking for a solution, but no one's been able to find the solution. Interestingly enough, another policy that I would recommend that you read is the NHS 5-year plan. It was around 2015 where the 5-year plan was written, and it really said, okay, we need to address this issue. We have a shortage of doctors in our country. We have a shortage of nurses. There's a rise in these non-communicable diseases. People or patients who could be seen in primary care are going to secondary care. We need to find solutions. And what I realized was that there is a huge opportunity for pharmacists. Think about it, right? Pharmacy has we see over 1.6 million patients or people a day. 1.6 million people visit a pharmacy every day versus around 1.6 million people go to a GP surgery. 95% of people can visit a pharmacy within 20 minutes by foot in England. That is mind-blowing. And I then thought to myself, if we are able to in sync ourselves with the vision of the NHS, And what did the NHS want? The NHS wants solution to this secondary care issue. Every time a patient that could have been seen in primary care goes to secondary care, it costs the NHS. So as a pharmacist, you're accessible. You're the only healthcare professional that can be seen without a GP, that can be seen without an appointment. GPs, doctors, nurses, psychiatrists, architects, any other healthcare professional, you name it, you need an appointment. Pharmacist is accessible. You can go to see a pharmacist without an appointment. You can speak to a pharmacist then and there. Now that for me was just to understand this concept that, we have a huge opportunity if we can inline ourselves with the NHS. So I understood what the NHS wanted. So I thought to myself, okay, if I could provide a solution on a local level first, there is an opportunity for me to grow this and help other pharmacists also develop the service. I also started to find out what patients needed. What did patients want? And I did a survey. Again, that's the best thing to do. If you want to find out whether a service is going to work, ask your patients. And what the patients said was that, A, we are happy to pay for a service if you introduce it, but we also want to be seen. We want great healthcare. So I then naturally went on to the next step, and that was to develop my non-medical prescribing, because if you read the white paper, I felt that if you had a health hub, so not a pharmacy, I'm redefining my business now. It's not a pharmacy, it's a health hub, where we could offer screening, point of care testing, where we could offer, for example, diabetes screening using phlebotomy, or something as simple as doing a PSA test, prostate-specific antigen testing for that, where we can offer treatment for minor illnesses. We have an opportunity to do something really amazing. So, in sync myself with the vision of the NHS, capitalize on a market, there's certainly a market there, offer something different, because aesthetics had already been there and I wanted to innovate. I was really, really motivated to offer something totally different and not just do aesthetic, because that's been there for a long time. Offer this one-step solution, because community pharmacy for me is a one-step solution. And then build this health hub, this idea that patients could be seen then and there. Patients could be treated for minor conditions then and there. And be an innovator, because as I mentioned before, aesthetics had already existed, aesthetics had already been there, but we've got this opportunity. So naturally, I went on to do my non-medical prescribing, and that was at Anglia Ruskin University. For those of you who are not non-medical prescribers, you normally do around 6 months of training, and you have to do something like 90 hours with at that time, it was a designated medical practitioner. Now, if you look at the recent GPHC guidelines, it's a designated prescribing practitioner. So in theory, a pharmacist could also supervise someone who'd like to go into non-medical prescribing. And I had the most amazing time with the doctors. And I thought I was ready. I thought after my non-medical prescribing, I've got this. Just like the doctors, I'm going to be able to prescribe, I'm going to be able to treat, and everything will fall into place. The reality is something else. That's not what happened. And I still remember my first patient who presented to the pharmacy. Now, my knowledge on anatomy was very basic at that time. My knowledge on history taking was very basic at that time, because unfortunately, I soon realized that universities are not, that particular course is not there focusing on clinical skills. And I had this patient who presented with, at that time, what was a sore throat. Looking at it now, I'm able to mention, it's bilateral swelling of the cervical, lymph node, had a temperature, presence of pus. But you imagine seeing this patient with a sore throat. There are numerous causes of a sore throat. It could be something as basic as a bacterial infection. It could be something as basic as a sore throat. Sorry, I'm just going to have to unmute some new joiners so I can kind of hear them, and they're kind of interrupting in what I'm saying. I do apologize for that. So I wasn't comfortable treating this patient. Now, if you think about the diagnosis of a sore throat, we have bacterial, so it could be simple tonsillitis, could be infectious monoclonalosis, which could go on to lead onto glandular fever, could be quinsy, which is a peritonsillar abscess, could be an abscess in the retropharyngeal space, could be an abscess that's in the peripharyngeal space. How do you make that diagnosis? And I was not prepared to risk my lack of knowledge for this patient. So I turned her away. I gave her consulting feedback and I said, I'm not prepared to do this because I'm not at that level yet where I can diagnose this condition. Diphtheria is a long, that's a far-fetched, that, the chances of a patient presenting to you with a pseudomembrane is very, very unlikely now because of the vaccines that we have. But, a simple sore throat may look like a sore throat to you, but can be a lot more. And I wasn't ignorant. I understood that all the patients that I saw when a doctor had prescribed phenoxymethyl penicillin were all the patients that had bacterial sore throat. But what about all the patients the doctor saw that referred? Just because you work in a pharmacy or you see phenoxymethyl penicillin or you see dentists prescribe to you amoxicillin or metronidazole doesn't mean that every single dental infection is a basic infection. It could be a root canal. So I had to draw a line to that. So something had to happen because I had invested close to £20,000 in non-medical prescribing. 90 hours of not being there, examinations, having a locum. I had financial pressure. So I decided to then go on and develop my aesthetics practice. That was my next step. And in developing my aesthetics practice, I was always reflecting that what had gone wrong with my prescribing. And it's 4 basic points. I didn't have the experience. I didn't have a support network. Now, if you look at a doctor, when he does 4 years of education, he then goes on to spend 2 years in practice. He does his final year, FY1 and FY2, which are your foundation year 1 and foundation year 2. You have a junior doctor, a senior doctor, and a patient, and he's always getting that support and he's always learning. He's not left alone. But let's think about a pharmacist in a pharmacy. You're the only person who's there. So I didn't have the experience, I didn't have the support. And the reality is I wasn't even able to reflect on my practice. If I had a patient who presented with a sore throat, how do I know what it actually was? Certainly I could have said, yes, a basic sore throat, but was it just a basic sore throat? What if a patient presents to you with an earache? How do you know it's not otitis media, otitis externa? How do you know it's not mastoiditis? How do you know it's not a furnicle or a carbuncle or boil? So I wasn't able to apply my basic knowledge and theory to practice. So when I did my aesthetics, with the will of God, that started to do extremely well for me. And I started to develop my competencies. And again, I started to develop content. I'm just going to play this brief video of the sort of videos that I started to develop. Again, that's really important to make sure that you do develop your content. And this was me just doing a video on fillers. Just a word of caution, anyone who does not have an understanding of anatomy, I seriously would not recommend that you go on to aesthetics. As there are huge issues and safety issues surrounding the practice of aesthetics. So make sure that wherever you go to, you do have an understanding of your anatomy. You definitely don't want to be putting needles in people's faces without understanding anatomy. And once I started developing an income of around £10,000 from my aesthetics business, I then went back to the real issue. And that is non-medical prescribing. Because you see, the issue with aesthetics is I myself didn't want to become a specialist in anything. I didn't want to be a specialist. I wanted to be a generalist. And there was nothing stopping somebody else opening up an aesthetics practice. There's no one, nurses can do it, dentists do it. I've seen cardiologists do it. I've seen beauticians do it. So I knew at some point I had to address the non-medical prescribing. And with the will of God, my wife, who's a doctor, got in touch with her consultant, Dr. Akib. And I remember asking him, and I said to him, Baijan, which means brother, is how do I become good at non-medical prescribing? How do I start to develop my prescribing competencies? And he said to me, the first thing you have to do is to humble yourself and start to educate yourself. We're happy to buy a new phone, we're happy to have the new car, we're happy to buy a new laptop, but the most important chip is your brain. You need to always educate yourself and develop your skills. And that's what I started doing. I started learning my anatomy, I started brushing up on my physiology, I started spending time with Dr. Akib, and I had the privilege of doing dissection, and I spent 6 months in human dissection, top to bottom. And again, it's not for everyone, but anybody who's actually interested in doing human dissection, we are doing a course next year, so do let me know, but it's an amazing experience. And I started to learn, because anatomy and physiology are what I'd say is the handbook to the human body. If you have a good understanding of anatomy and physiology, you're going to have a very, very good understanding of what's physiological and then compared to normal. Let me give you an example, right? You have a patient who has a temperature. This patient has a temperature, but his pulse is also raised. Why is that? Well, if you go back and look at physiology, we understand that if you have a raised temperature, you have an increase on, calcium ion, Ca2 plus through the sarcoplasmic reticulum. And that has an inotropic effect on the heart, and your heart rate increases. So that's physiological. That is normal, that a patient who presents with you with a temperature, for every 1 degree, you're going to have an increase of around 10 beats. So by understanding how the human body normally functions, you can really start to develop your skills. And having that basic knowledge is so, so important, absolutely important to make sure you do that. And I started to learn cytology, histology, pathology, and I started to develop my skills. And as you're probably aware, if you're not aware of the post that Eliza did for me at the Chemist and Druggist, I set up my clinics. I've got a clinic with the will of God that's doing extremely well now. I'm able to now set up this new sports clinic where I actually undertake the administration of steroid injections should it be appropriate. And if you want to get in touch with that, do let me know about that. But if you've got knowledge, you can build on that knowledge. The more you learn, the more you educate yourself, the easier it becomes. And then I set up MedLearn. And MedLearn is an organization that is there to give you the clinical skills that you need as a professional. Whether you're a pharmacist, nurse, or doctor, doesn't matter who you are. I have this vision that irrespective of who we are in this world, doesn't matter what age you are, what color, what race you are, we all have a fundamental right of having great healthcare. And I believe by educating healthcare professionals all over the world, giving them the skills, giving them the financial skills as well to do well, we can offer a great service to these patients. And that's what we do through our training program. Now that's part 1 completed. Again, apologies that everything's happened so fast and in a bit of a rush, but that is kind of what you need to be thinking in terms of how the community pharmacist contractual framework came about. Have a read of the RPS Now or Never. Have a read of the NHS 5-year plan. Have a read of the NHS 5-year forward view. Have a read of the NHS interim plan, write this down. Have a read of the Health Education England workforce strategy. Then read the NHS 10-year plan, and the community pharmacist contractual framework will make all sense to you. You'd also understand where it's headed in the future. Eventually, what they want is to allow GPs to refer patients to us. So how I see it is you need to develop the clinical skills. It's going to be a must, and I don't see any other way. What's stopping Amazon from slashing dispensing into half and getting a contract? Think about it. For me, I think it's the writing's pretty much on the wall. Anatomy. Now, why anatomy? Now, anatomy, we've already touched on it. Anatomy gives you this beautiful understanding of the human body. It allows you to relate to structures. It allows you to understand how the structures work and their function. It allows you to name parts. If you don't know what the parts of the human body are, you're going to struggle to be able to develop your clinical skills. I'll give you a simple example. Earache, right? If you read any book on pathology, which is the study of disease, and you want to learn about earache or pick up a book on internal medicine, it's going to mention about the ear, and it's going to mention any sort of tenderness around the tragus or the pinna could be a sign of otitis externa. If you don't know what the tragus is, or you don't know what the pinna is, how are you going to develop your skills? Also, when you're having conversations with other healthcare professionals, you want to make sure that you raise the bar. You want to make sure that you raise your profile. So anatomy will teach you the basic naming of the human parts and their functions. So you can then go on to learn how functions happen, which is physiology, and then you can go on to develop your skills in pathology and the natural cause of disease. What is anatomy? It comes from the Greek letters ana and tomi. Tomi means to cut, ana means up. So basically what you're doing is cutting up. That's literally what anatomy is. How you study anatomy. Now there's various ways to study anatomy. I'm actually going to be focusing on surface anatomy with you because I think that's more relevant to what we need to learn. Regional anatomy is focusing on dividing the body into regions, for example, head, ears, nose, throat, abdomen, thorax, the lower part of the body. Or you could go with a systems approach. And a systems approach, I think, is really, a systems approach can get a bit complicated because you're combining all the different structures. So you're going to be learning about cardiovascular system, the respiratory system, the integumentary system, digestive system, muscular system, the urinary system. And I think it's a bit too much, but surface anatomy is certainly what you should have an understanding of. And that is to do with looking at parts and be able to relate the parts that you can see to the external structures. Microscopic anatomy is mind-blowing. I don't recommend, unless you've got a lot of time, I don't recommend that you actually look into that. But microscopic anatomy explains to you how things happen on a cellular level. There's something you need to understand. Everything that you do or everything that happens in the human body is on a cellular level. When a clinician is treating your tonsils, what he's treating is the epithelial lining of those tonsils that make these nodes. To you, you think that he's treating tonsil, but what he's treating is your cells, right? When you have myocardial infarction, what's the problem with myocardial infarction? Think about it. What's happening is muscle cells are dying. And if muscle cells die, your heart's is not able to pump blood around the body. And we need that oxygen for ATP, which is the currency that your cells use to continue on their work. So, histology and cytology is mind-blowing, but do you really need to know it at this stage in time? Probably not, because you really want to focus on everything and you can't learn everything. So what you want to learn from anatomy, and we're going to be touching on this, is the different parts of anatomy. So when you see a patient and you're measuring the pulse, you understand, am I measuring the radial pulse? Am I measuring the ulnar pulse? You're aware, what are you touching here? Is this the preauricular nodes? Is this the juxtadiaphragmatic or the tonsillular nodes, the submental nodes, submandibular nodes? So you're able to raise your profile. And then you'll also be able to understand physiology. If you pick up a book on physiology and you don't know anatomy, it's going to be very difficult for you to understand. History taking, this is so important. The first thing that I was taught was the importance of taking a history. And how I'm going to explain this to you is, think of yourself as a detective. You are a detective and you are gathering information. History taking is your chance to gather that story from that patient. Why that's important is because you need to be able to gather that story from that patient and compare that story to a different disease state. And I'll explain that to you and how you make sense of this. But history, and we've all done history taking. Anyone who says to me they've never taken a history, it is impossible. Whether you're working behind the counter, the soonest you ask a patient a question, which is how long have you had your symptoms for, you're taking a history. That is basically it. Whether you want to use a structured model or whether you want to use a basic model is down to you, but I will always suggest that you use a structured model and develop your competencies. So why is history taking important? Because history taking allows you to formulate a diagnosis. It allows you to think about the symptoms that you have and what they relate to. Because patients present with symptoms. Unfortunately, a patient is unlikely to present to you and say, I have otitis externa, or I have otitis media, or I'm suffering with GORD, gastroesophageal reflux disease, or I'm suffering with, a frozen shoulder. They're going to come with symptoms. So you have to be able to relate these symptoms to the disease states. It allows you to compare stories because it's all about stories. If you know a particular disease state in a book, for example, you read a disease state. Let's take myocardial infarction, right? So a heart attack. What are the symptoms that you'll get with a heart attack? You'll get chest pain. You'll get pain that's deep. You'll get pain that might radiate to the ulna or to the different various parts of the arms. You get pain that radiates to the back of the shoulders, to the jaw. So you know this in a textbook, right? You then ask a patient who presents to you with a chest pain, and he says, I've got chest pain. And you ask him, how long have you had this chest pain for? And he said, it's sudden. Why do we ask if it radiates? The reason you're asking if it's radiating is you're thinking that if it's some sort of cardiac cause, it may radiate. Whereas something like GORD doesn't normally radiate, it normally stays more central. And the reason it doesn't radiate is to do with the pathology, because what was happening in GORD is you have the sphincter, the esophageal sphincter that's compromised and is not able to close appropriately, and it prevents the contents to go backwards. But when you have GORD, unfortunately, it does come backwards, and that's where you get this heartburn. So it allows you to compare the two stories. History taking also allows you to decide what two systems you want to investigate, or the various systems you want to investigate. Because if you're not able to know the systems you need to investigate, you're not able to do a diagnosis. For example, a patient with shortness of breath could be exacerbation of asthma, could be COPD, could also be left ventricular heart failure, could also be something like a pulmonary embolism. And as you start to set these clinics up and start to develop your clinical skills, there's a chance that you might have a patient who presents. I just had a patient last week who presented with pitted edema who I had to refer because I was worried about ADVT. So eventually this will start to happen, and you'll soon start to realize that history is so important. And I'll give you an example in a second. So history taking, is it an art or a science? I think it's both. The science part is you understanding the science, and the art part is you being able to gather that information from this patient. Something I always struggle with is, and I still struggle with now, is children. It's really difficult to gather a history from a child. Sometimes they don't just want to talk. Some children obviously can't talk for obvious reasons. So gathering that information is important. Again, I was speaking with Dr. Amir, who actually explained to me how you actually get to really have a look at the oral cavity or the mouth, because every time I'd use a tongue depressor, I couldn't get that tongue to actually depress and go down. And he gave me a wonderful tip that's made my life a lot easier. So yes, there's a science to it, but it's also an art. And I think it's the combination of both. Your history taking has to start from as soon as you see the patient. The moment that he walks in to your clinic, you are taking a history. You are looking at that patient, you are observing that patient, and you are thinking, right, this patient who's walked into my clinic, what am I thinking about this patient? For example, if this patient is sweating, he's not able to hold sentences, could it be that this patient is suffering with something that I am not the right clinician to deal with? Not because you're not capable, everyone is capable of learning. It's because what tools do you have as a pharmacist or even as a GP? Again, hats off to GPs. You've got your hands, you've got your eyes, and you've got your ears, and the patient's story. So sometimes you're not able to reach a diagnosis just based on that. Again, the example of a heart attack or myocardial infarction, doesn't matter what history you take, you still need to do an echo. You still have to check for troponin levels. It's impossible for you to diagnose a patient that this person's definitely having a heart attack. So your observation is going to be important. You need to make sure that you're aware of palpation, and we'll be discussing that when you're going to touch patients. There's also going to be percussion, and percussion is where you're using the various You're using your hands to listen to different sound structures. You'll be seeing doctors doing this because you're trying to relate the sound to the underlying structures. And auscultating. Auscultating is where you're using a stethoscope to listen to the various sounds. So history taking and a physical examination will encompass all of this. Do you need to know it as a pharmacist? I would say yes. Why? Because eventually you are going to need these skills. Have a look at the CPPE tender that they sent out for training companies and what they want to teach pharmacists in April 2020. Everything I'm talking about, they want to be teaching next year. It's where the pharmacist is headed. You need to write this down. This is such an important slide, and I've put this slide in red for you. You need to write the structure down because this structure is going to give you the opportunity to start to put this into practice. And history taking, I feel there should be a structure to it, so you're always able to learn. And you start off with your presenting complaint. You can label it as PC. Presenting complaint literally is the headline story. Why is the patient here? So I will always start out by writing PC. Okay, 20-year-old patient presents with sore throat. 10-year-old child presents with earache. 30-year-old female presents with frequency dysuria. That is your headline structure, your presenting complaint. You then have the history of presenting complaint. That is your chance to gather information from your patient. And there's many acronyms, but I like OLCOT. It talks about making sure you gather the onset, when the symptoms started, where the symptoms are located, the duration, the characteristics, the aggravating factors, the associated symptoms, the relief, and the treatment. Again, this same structure throughout the webinars I'm going to be going through and giving you practical examples on how you do this. But let's work through one, which we'll go through in a second. Sore throat. I'll give you an example of a sore throat. So you have a patient who, or a cough. You have a patient who presents to your pharmacy with a cough. When did your cough start? It started 2 weeks ago. Why is that important? Well, because a cough that's been going on for 2 weeks is an acute cough. A cough that's been going on for 3 to 6 weeks or slightly more subacute, and a cough that's been going on to 8 weeks is normally a chronic cough. And depending on your duration of symptoms, the diagnosis is totally different. A chronic cough has different diagnosis to an acute cough. Acute cough could be left ventricular heart failure, could be pulmonary embolism, could be just an upper respiratory tract infection, could be GORD. There's many causes to an acute cough. Could be bronchiectasis, could be exacerbation of asthma. The location of the cough. Do you feel that it's on the chest? What are the characteristics? Is it a dry cough or a chesty cough? A chesty cough that has presence of mucus could suggest possibly an infection. And we know that mucus normally is clear. And the moment you start to introduce different colors, it could be presence of neutrophils, which are white blood cells, and that suggests that there's an inflammatory process. What are your associated symptoms? What if this patient said to you, I'm having a cough and I'm also coughing up blood? Totally changes the diagnosis. What makes it better for you? What makes it worse for you? The cough always happens at night. You're thinking night cough, possibly asthma. Night cough, possibly fluid in the chest or the lungs. What treatment have you tried before? Past medical history, again, something really, really important. You need to know your past medical histories. Let's give an example of a patient who presents with a rash. This patient has a rash, and this patient also suffers with asthma. You look at the rash, it's well defined. It's what we would say is a macule, so it's not raised. It was a patch, so it's not raised, and there is presence of this whitening or scaling, and this patient's also suffering with asthma. We know asthma is an atopic condition. You're able to link that, okay, this patient may have eczema, because we know eczema is also an atopic condition. So risk factors in any history are so important. Again, you will learn this as time goes on. You will learn to be able to compare and contrast the disease states. So don't panic about it too much. We also have the family history. Now, the family history again is so important because we know that certain disease states can also influence the diagnosis. For example, if a patient presents to you with a cough and he's got a family history of, oropharyngeal, carcinomas or cancers, you need to be thinking about this. Social history, again, smoking alcohol, right? what doesn't smoking actually cause? We know it causes cancer. We know it causes cough. It's there. And again, smoking can also cause a sore throat, can also cause GORD. Alcohol, again, is a risk factor. Allergies, medicines, we know this. Travel history is so important now because we're now traveling all over the world. We're now going to destinations that we probably didn't used to visit before, but we're going there now. So again, that's going to be important to make sure that you certainly do have an understanding of travel. Sexual history. You have a patient who presents with dysuria or symptoms of what you might think is a urinary tract infection. But males can also have prostatitis. Prostatitis is inflammation of the prostate, and that can be caused by a sexually transmitted infection, can also be bacterial infection. So that's also going to be something that's very important to consider as well. And the reviewing of systems. Again, I don't mean here that you go and undertake a physical examination of every single system, but it's going to be important to make sure that you are asking them the necessary questions. So if I had a patient with a sore throat, I would still inquire about the ears. Do you have an earache? Can you hear? What about vision? How are eyes? What about the cardiovascular system? Do you have any chest pain? Do you have shortness of breath? Because if I've missed out something in my initial history taking, I can cover it the other way. Quickly, how you put this into practice. Well, rule number one, you will always assess the patient. And I explained to you about making the observation. Is this patient who I'm seeing now acutely unwell? Rule number one. Rule number two is remember that you are always observing your patient, how he's walking, how he's dressed. This will be very important as you start to develop your knowledge on disease states. You know, it's snowing outside, this patient's wearing shorts. Could be a mental health issue, could also be made possibly thyrotoxicosis or issue with his thyroid function. You need to always remember A, B, C, D, E. Airways, can he breathe? Can he talk? Circulation, you know, is he conscious? And remember, you're comparing stories because patients present with a symptom. If a patient presented to my practice with a sore throat, I'm straight away thinking, okay, sore throat, what are my differentials? I have a upper respiratory tract infection, for example, tonsillitis, could be something like, you know, could be an ulcer, could be candida. Okay, so these are the three most common ones. I'm also thinking of the other differentials that could be a retropharyngeal abscess, could be quinsy, could be, you know, where you have chondritis, which is a condition, or chondrotina, which is a condition where you end up having this pain of the carotid arteries because it starts to constrict. So you always need to have 2 or 3 alarm, what I would call alarm diagnosis. The last thing you want to do is misdiagnose a patient. And you have a short time to make that diagnosis. So you definitely, you know, I'm not advocating this, but it's, you know, ruling out a bacterial infection is one thing, but making sure that this person doesn't suffer with TB is another thing. A patient that presents with a cough, night sweats, been abroad, could have TB. So you always need to be thinking of these conditions that are more severe that could really cause, you know, problems to your patient in terms of making sure that you're able to put this into practice. So I always look at my patients. I always, once they've started to mention their symptoms, I always make sure I have my differentials in my head. If you're talking about an earache, I'm thinking otitis media, otitis externa. I'm thinking possibly trauma. I'm thinking maybe it might be could be a carbuncle or a furnicle, could be mastoiditis, something that's an alarm feature. So could be temporary mandibular joint dysfunction, could be, you know, trigeminal neuralgia. So I'm always thinking, and then I'm comparing the stories. By knowing your understanding of physiology, you're going to be able to rule out otitis media from otitis externa. Otitis media, for example, we know that the eustachian tube, the pharyngotympanic tube, is actually connected to the nasopharynx. So we know that that tube itself actually connects to the nasopharynx. So you have a patient who has earache. He or she also mentions you have had recently a sore throat. Link the two together. It makes sense because the tube itself connects to the middle ear. We'll be looking at that. So there's a higher chance that they might have otitis media. And then always examining at least 2 systems. I would always say that you examine at least 2 systems. if you're a pharmacist, for example, working in community pharmacy, you might argue, why should I do an examination? My take on it is, if you're going to make a decision on prescribing, you need to keep that at the back of the mind. The examination might be just you looking at the throat. The examination might be you taking a pulse. The examination might be you taking a blood pressure. But it's all the same thing. You don't have to go into depth, but the more knowledge you have, the more you can build on it. How have I been able to build on my success? It's been the knowledge I have. So the more you learn, the better. And before I developed my clinical skills, I'm a contractor. I understand how you run a business. I understand the need to continually learn and redefine my practice. So, you need to make sure you develop your skills. So I would recommend that you study and gain knowledge. I'd recommend that you learn the different disease states. I'd also recommend that you practice history taking and learn the structure of history taking. We're now moving on to part 4, and it's the ending part. And this is anatomy of the ears and the throat. What do you need to know? Okay. Let's have a look at the ear. So now this is your chance to now put something into practice. This is the practical side of things, which you need to hone into and really pay attention to this. And I'm going to teach you what I feel you need to know. First of all, when we look at the ear, it's divided into 3 sections. You have the outer ear, you have the middle ear, and you have the inner ear. And I'm going to break this down into 3 separate sections for you. We have the outer ear, middle ear, inner ear. You need to know this. There is absolutely no reason why you shouldn't know that there's 3 compartments in the ear. If you are going to make any sort of diagnosis of an ear infection, there is no way you don't understand this basic concept. What are the functions of the ear? Can anyone on the chat quickly send me 2 functions of the ear? That'll be interesting to know. Give me 2 functions of the ear. Anyone send me 2 functions of the ear? First one is hearing. What's the second one? I'll count till 3. If no one's got any suggestions, I'll give you the answers. So the first one is hearing. The second one is balance. Balance, your ears are also involved in balance. Now that is mind-blowing, because what you find is what we call the vestibular apparatus, or the vestibular apparatus. It is involved in the balance. And I won't go into too much depth in that, but your ears have 2 functions, hearing and balance. Just remember that. It's divided into 3 sections, the outer ear, the middle ear, and the inner ear. Let's look at the outer ear. What do you need to know? Guys, you need to know this. Not everything on the slide, certainly not. What you need to know is what the tragus is. Please make sure you know what the tragus is, because the tragus is this part here, okay? The tragus is the part of the ear that you can actually palpate, and you can press inside and links directly into the auditory canal, or the external acoustic meatus, which is the tube that connects to the middle ear. It's this tube here. And this is an important landmark, what we call with surface anatomy, because if you have a patient and you palpate or feel the tragus and they have pain, it can suggest that the infection is located in the outer ear. So know that's the tragus. Understand that the ear has a helix. That's the triangular fossa. You don't have to know that. Fossa just means depression. This is the concha. This is the antitragus. What you need to learn is that this is a landmark that's really important. So this part of the ear, I'm not sure how clear it is the tragus. Have a feel for it. And next time you have a patient who presents with a prescription for otitis externa, do have a feel of the tragus. And you'll see that the moment you touch there, or the moment you pull on the ear, they're going to have pain. This is also known as the auricle or the pinna. So 2 things you have to remember, that the outer ear is known as the pinna, and this structure known as the tragus. Just remember that. Okay, so let's have a look at here, and we're having a look at the tympanic membrane. And this is where we're looking at the middle ear. And again, this is going to be something really, really important, because when we go and look at the middle ear, which is right there, that's what you actually see. If you've never seen the middle ear, I would recommend that you go and undertake otoscopy, and the otoscopy will show you this structure. It's not difficult. Literally what you're seeing is here. What you're actually seeing is that structure there. And what you have is the two different regions. You have the pars tensor. This contains connective tissue. I won't get into that. And the pars flaccida, which actually doesn't contain connective tissue, but it's actually it's actually quite weak. In actual fact, having a perforation or a hole in here, very serious. If you have a patient that presents with an earache and you look at the tympanic membrane and you find that there's a perforation here, that is a medical emergency. Why? Because if you look at the anatomy and we go backwards slightly, what you'll find is that there's a space here. So if you have a perforation at the pars tensor, or sorry, the pars flaccida, the infection can technically go into this space here. And here we have the epitympanic recess or a cavity or a space which sits directly below the middle cranial fossa. And that is basically where the brain is. So imagine you had an infection here, right? And you have a perforation, and that infection can go into the bone and then infect the brain. So that's really important for you to understand that when you have a look at this structure, any sort of perforations here are really, really important to make sure that they are appropriately referred. We have the cone of light, and normally on the right ear, you normally get this at about 5 o'clock. And normally if you can see the cone of light, you're in safe hands. On the left ear, you normally see this at about 7 o'clock. So we have 12, 1, 2, 3, 4, 5, 6, 7, 8. So now 8 o'clock is normally opposite. We have this bone here, which is known as the malleus, and this bone is literally the 3 bones here. So we will review this anatomy later on, but when you do get a chance, have a look at the ear and see if you can see these structures. And this is the inner ear, and we have the cochlea, and this is where you have the endolymph, and we don't have time to go into too much depth in this, but this structure is very important for hearing. It connects to the vestibular cochlear nerve, and that's how sound that travels here will actually work its way to the bones. And once it works its way to its bones, it actually causes this fluid, what we call the endolymph, to start to move. And hair cells here will then send this information to the vestibular cochlear nerve, and you then end up getting signals going to the medulla oblongata, which goes to the thalamus and then to the temporal lobe, and you end up getting sound. So it's a pretty complex structure, but just remember that this structure here is also involved in balance. So what do you need to know as a summary? Know what the tragus is, know that the ear is known, the outer ear known as the pinna, have an appreciation for this structure here, have an appreciation for that the cone of light is normally physiological and you would normally see it if things are in good shape, and understand that you have an internal organs or internal structure for the ears as well, which are involved in hearing and involved in balance. So that's the ears. Quickly, let's touch on the throat, right? And just have a look at that. What a beautiful concept. We have the throat that's divided into nasopharynx, oropharynx, and laryngopharynx. We can see here that we have the palatine tonsil glands. They're not, sorry, no, they're not glands. Okay, they're nodes. I know colloquially we all use the word glands, but tonsils are not glands. Please remember this, tonsils are not glands. Tonsils are nodes. A gland is an epithelial lining of tissue that can secrete hormones or different chemicals into a bloodstream via ducts or without ducts. Tonsils are not glands. They don't secrete hormones or they don't secrete chemicals into the bloodstream. What they do is they work as nodes. They're lymph nodes, and they collect and work to aid the lymphatic system, and that is basically involved for fighting infection. So just remember that, yeah, we all mention your glands are up, but it's not your glands that are up, because the only glands you have here, one of them is a parotid gland, salivary glands, and submandibular glands, and so forth. But the palatine tonsil is something that you can actually visually see. You can't see the pharyngeal tonsils here, and you can't see the lingual tonsils. You can see the uvula, and that's the dangly part that is, again, a landmark for someone who presents with quinsy. If this patient has quinsy, you may find that the uvula is deviated. And we've got the hard palate and the soft palate. And again, if you were to start to wiggle your tongue around in your mouth, you'll soon feel a hard part, which is the hard palate, and you have the soft palate. The hard palate is made from keratin. It is also squamous epithelial. The soft palate is also squamous epithelial. It's not really relevant, but you just need, it's good for you to have that kind of understanding of this. But in terms of the structures that you need to be fully familiar with, that is this. You need to have an appreciation of the uvula, which is here. You need to have an appreciation that this is known as the pharynx. And these are the tonsils here. And these tonsils are the palatine tonsils that you can see. And should they be swollen, you have possibly a chance of an infection. So again, I made a point of this, that these are lymph nodes. These are not glands, these are lymph nodes. Okay, you should know the lymph nodes, because if your lymph nodes are swollen, there's a chance that you're having an infection. Just have an appreciation of this slide. If you can remember it, fantastic, but just have an appreciation of this slide, that you have the periauricular lymph nodes here. You have the posterior auricular lymph node just behind the mastoid bone or the mastoid process, the occipital lymph nodes. So that is literally a quick overview of pretty much everything that we've gone through. And that's going to be something that's going to be really important. So just a final summary. Make sure that you know that the ear has two functions. Make sure that you continually learn and develop your history taking skills. Remember the structure. It's presenting complaint PC, history of presenting complaint, which is you comparing the stories and gathering the information. It is also you gathering the family history, social history, sexual history, travel history. Just literally, I'd advise write it down, write it down. And we can go through that later on if anybody's got any questions regarding this. And, it's already late and I haven't voted either, actually. So I need to go and do a vote as well. Without taking too much time, I am happy to address any questions that you have on what we've discussed today. So anybody who'd like to ask a question can post it on the chat and I can unmute you. And we can take it from there. Now, you're more than welcome to ask me a question. I think you're able to raise a hand, and I think it'd be probably better if everyone actually would probably just message me on the chat. Anybody's got a question. There's one here, and that is about, someone's put down about, oh, there's so many questions, right? So how are we going to do this is I need to scroll up. Let me answer the first one. Is where did I get aesthetics training? Okay, that's a good question. Where did I get my aesthetics training? Right, okay. So that is from William. Right, William. Here we go. I've unmuted you. Good evening, William. You should be able to hear me now. And if it doesn't work, I'm not going to spend too much time in there. Right. Okay, so we're having, okay, fine. Sorry, you don't have a mic. Okay, that's fine, no worries. Okay, so where did I get my aesthetics training? I did my aesthetics training with Dr. Camille, who's a plastic surgeon. And I also did my cadaveric training with Dr. Akib. But in terms of where I actually went to do aesthetics, that was with Harley Academy. That's what I did my aesthetics training. Before you start spending any money on aesthetics, please get in touch. Please get in touch, because I spent so much money on my aesthetics training, close to like something stupid like 10 to 15,000 pounds. And you don't need all that. I'll be very honest with you, you don't need all that. So I've left my number here, 0749761943. William, get in touch, send me a message, I'll go through it with you. No problem. Hearing and balance. What about hearing and balance? What do you want to know about balance? What would you like to know about balance? It's difficult for me to answer just a question on balance. What do you want to know about balance? Oh, right, you answered the question. Yes, thank you, well done. Right, spot on. Yeah, hearing and balance. Yeah, thank you, well done. Perfect. Bobby, you've asked me a question, the transmission of info to the cerebellum. Why would you really, like, on a Thursday night, do you really want me to go into the the anatomy and the transfer of the information? I'm more than happy to. You're saying nope, just joking. I'm happy to sit here and talk about the cerebellum. We can talk about the prosencephalon, we can talk about diencephalon, telencephalon. We can go into the the rhombencephalon and really divide that. But I don't think that'll be relevant for pharmacists at this very moment in time. But between you and I, you're more than welcome to get in touch with me on a Thursday night, and we can discuss that as much as you want. Anybody else got any other questions? Okay, someone asked me what reading material I recommend for learning anatomy and physiology. Right, good question. First of all, certainly I don't recommend that you spend days and years and months on anatomy and physiology. Don't do that. You don't need to do that. What you need to do is be very structured in your learning. So anatomy and physiology, there's a book that I'd recommend, and I can get Sadiko to recommend that to you guys, and I can send that. It actually breaks down anatomy and physiology perfectly for pharmacists, and it's something that you'll find useful, and it's literally very practical, because what you don't want to start learning is anatomy that is too much in depth. You don't really want to start to go into histology and cytology and pathology. You want to learn pathology, but you don't want to go into too much that, because that won't be relevant. You can't see the cells, right? So just ignore that. But I will send a book on the link itself. We've got a question from okay, Samra, thank you. You said you teach clinical skills within your practice. How would you go about how would you go about doing this? So I'm guessing you're asking, I'm assuming that the question is, how do I teach clinical skills? Is that right? Samra, is that what you're asking me? How? What's the question? Yes, certainly we do have a program. The program is, okay, fine, yes. Right, so Medlearn is the training company, and we do have a program that teaches you clinical skills. So it teaches you how to take a history, it teaches you about physical examination, and it's led by the doctors, and it teaches you everything that you need to know to put your theory into practice. It will go through exactly how you take a history. It will go through the different disease states. It will go through how you will start to develop your competencies. So I'll send you the link for the training courses, but we teach you everything from anatomy, physiology, to history taking, physical examination, to minor illnesses, the whole works. So I can send that information to you certainly about that. Sadiq, it's a valid point, right? You mentioned ENT, because I always get this question. Everybody is always so interested about red flags. So give me what do you want to know? A red flag for sore throat. Okay, let me give you some red flags for sore throat. Right. So I think Bobby, you've mentioned some valid points, but I think diphtheria is something that's really, really unlikely now. I would probably avoid the diphtheria, because with the presence of vaccinations, it's unrare. And if you had a patient who had diphtheria and they had this pseudomembrane, it could lead to epiglottis, you would know. So red flags for sore throat, right? If I had a patient who wasn't able to hold sentences, was drooling, right? So not able to hold sentences, drooling, dysphagia. So dysphagia means where you are unable to actually swallow. It's different from pain on swallowing. They're two separate things. Dysphagia is different and odonophagia is different. Odonophagia I'm happy with. Whenever a patient actually presents and says to me, I'm having difficulty swallowing, I say, can you drink a glass of water for me? If you can drink a glass of water, you don't have dysphagia. So that's another red flag. If a patient had symptoms of a sore throat, but I couldn't find a direct cause for it, that would be something concerning, right? Ear. If you go onto the ear and a patient presents to you with discharge, straight away you need to be thinking discharge. Where is that discharge coming from? Is it from the tympanic membrane? Is it from is it otitis externa? Is it just the epithelial lining of the the canal? That would be a red flag. Any pain here, guys, any pain around the mastoid area is a red flag. Absolutely red flag. Any pain around here. If you have any pain, I don't care what symptoms they have, but they say I've got pain around this area, that is possibly mastoiditis, and I won't go into depth, but you're looking at possibly the infection going to the epitympanic recess, working its way to the tagnon tympania, working way to the middle cranial fossa, and I can explain that. Now, how do you develop your clinical practice? William, very good question. So I have, and I think it's a beautiful question you've asked, because that is so important. So what do I do now? With our training program, we also give you access to doctors. That is the most important thing that you need, is you need a mentor. You can't do this without a mentor. I don't care how smart you are. I don't care how much knowledge you have. It doesn't matter. It is impossible for you to do this without a mentor. So what do I do? So on our training program, we have Dr. Akib, who's an A&E consultant. We have Dr. Kalgar, who's a dermatologist. We have Dr. Camille, who's a plastic surgeon. We have Dr. Amir, who's a GP. We have Dr. Albi, who's a GP. And we have various nurses and nutritionists. So I will always, always, always reflect on my practice. Every time that I have a case with patient consent, I discuss it with my doctors. And Dr. Amir told me something about, always reflecting on your practice. And he mentioned this acronym of DINs and PUNs. And he talked about the doctor's unmet needs and the patient's unmet needs. So again, I will always make sure that my examination, I will always do a follow-up with my patient. I will always ensure that these patients, the symptoms, the treatments are working. So for example, William, if you presented to my pharmacy today with any symptoms, I would certainly do a follow-up tomorrow. I will give you access to my contact number, which is available 24 hours. So I have a separate line set up for these patients. And I will definitely give you a call tomorrow to see how you're getting along, because I want to evaluate how you're getting along with these disease states. I want to evaluate, has my treatment worked? For example, a UTI, right? We know that within 24 to 48 hours, the bacterial load will normally decrease. So if I had a patient who's suffering with a UTI and I call him within 24 hours and he goes, no improvement, and within 48 hours, absolutely zero improvement, I need to review my diagnosis. I have to review my diagnosis. Either there's resistance, or the issue we're having here is possibly the diagnosis is not correct. So I am always learning. I'm always in contact with the doctors. Again, the training program gives you access to this. We give you access to doctors. We give you access to the different clinicians. So you always can reflect on your practice. And it's a question that I was asked by the GPHC. is how do you do my development? I'm always learning, I'm always reflecting, and I'm always in discussion with the doctors. I recently had a question with Dr. Amir with a patient who presented with symptoms that looked like an ulcer on the actual, the dangly part of the uvula. And I got in contact with GPs all the time. So I am always learning. Any advice on how to move from community pharmacy into primary care? Should you really complete the IP course first? Right. No, I made that mistake. You develop your clinical skills first, you then go on to your IP. Because if you have a look at the definition of an independent prescriber, you're prescribing within a conditions that you are comfortable with, because the independent prescribing course does not give you clinical skills. Again, as a training company, we provide you with all the training that you need. So before you do your IP, you need to develop your clinical skills. And how to move from community pharmacy into primary care, that is where you need to develop your clinical skills and then sync yourself with the vision of the NHS. What does the NHS want? The NHS wants you to help with reducing patients who could be seen in a primary care, stop them from going to secondary care. That's what it wants. If you can offer that solution, you're going to get a contract. That's why I'm really skeptical about pharmacists having these and no disrespect, Dr. Amir, if you're listening, having these GPs doing their consultations on your perch. Why? Why are you not treating these patients? Why should these doctors be taking your data and developing skills and developing that information? It should be you. It's your hard work. It's your patients. It's your list. If we're not able to touch the list of other professionals, you need to guard your list, if that makes sense to you. Are you still working community pharmacy now with your clinics or within primary care? So I work within community pharmacy. A lot of my time is spent on my clinics and teaching. So again, Medlearn is a training program that we've set up. It gives you the various clinical skills on history taking, physical examination. It's a 3-day event that we host. You visit, you spend time with us, you get in touch with the doctors. We then do networking afterwards, and we're able to discuss business as well. So not only do we do courses in community clinical history and physical examination, but we also do courses on the minor illness, taking blood. Again, I do phlebotomy within my pharmacy. We also teach you how to get CQC registered should you need to. We teach you how to develop your skills for primary care. So all you pharmacists who are working in primary care or want to think about primary care, we have a specialist course on that as well. So the course will cover everything. And what I'll get Sadiko to do is probably on the chat or on the group, probably mention this. And if you're all happy, with the GDPR, I can't just randomly send you information. But if anyone isn't happy with me sending them information, please let me know and opt out. But I can send you information about our training program. But I didn't want this exercise to be a marketing tool. It doesn't matter where you go, whether you go to Medlearn or CPPE or ECG training or GPPT training. The point is that you need to regularly learn and educate yourself. Do you liaise with patients, GPs? Yes. Yes. It's very, very important for you to liaise with your GPs. Samra, thank you for mentioning that, because that is so important. Continuity of care is so important. Let me give you an example, right? You have a patient, and I'll give you an example. I had this patient who presented, thank you, Habib. I had this patient who presented to the pharmacy. It's a male patient, okay? And he was suffering with symptoms of a urinary tract infection. And this is really important because it was a male patient, and I went on and did a digital rectal examination, and I then treated him with ciprofloxacillin because once I did a history, it kind of made sense for me that that this might not be this might be an upper urinary tract infection. Being a male, he had back pain and so forth. And anyway, I treated him. I then sent that discharge letter, one for him and one for his doctor. In actual fact, you would need to send that information to the GP. So I give one discharge letter to the patient, one discharge letter for the doctor and one I keep on the file. So there's that continuity of care. So the doctor knew that I prescribed him ciprofloxacin. In actual fact, he had to go for an ultrasound because we both agreed that he might have actually had, what we call kidney stones. So yeah, you always, any treatment that I offer, there is always a discharge letter given to patients and their doctors. What advice would you give in newly qualified pharmacists, i.e. 1 year plus, in terms of building the clinical skills and moving forward? Okay, what advice I'll give you is the exact same question that you've asked now, is start thinking. Start to think about where you need to move forward. Start to attend clinical courses. Jump onto a history-taking physical examination course. You're at the best place to start your learning now. Go and educate yourself. Go back and start reading about anatomy, physiology, develop an interest. Visit the groups, get in touch, do your learning. Doesn't matter whether it's CPP, whatever course, or it's a Medlearn, the training company that we have, but educate yourself. My advice to you is learn. How you do that is by developing your skills with appropriate practitioners. You can't do it all alone. As much as you can pick up a book on a textbook, for example, I've told you about the tragus, but are you really feeling for the tragus? You need someone to be able to explain that to you. Sadiq, you mentioned Yasser earlier asked how do you record consultation in a community pharmacy? Right. So I normally, and anybody got any other questions? A couple of minutes left, and then we probably need to call it a day. And that is that I normally use a software that I've developed internally, and it's powered by Adobe, and everything is recorded on there. After I did my travel clinics, I had patients who would visit after about a year to 2 years for their records. So I soon realized that the paper copy isn't going to work. So it was an electronic version, and I saved that on my Adobe reader, and I was able to email that, give that copy. There's companies known as, there's Medbase, which I think is a company that do it as well. How do you access patient records in a private clinic setting? Very good question. How do you access patient records in a private clinic? Right. So if you're setting up a totally private clinic and you don't have a pharmacy, you don't have access to summary care records, it is more important for you to make sure that you are able to take a history. That is what I say to you. You need to be taking a history. You need to be able to gather that history. And if you really felt that it's not appropriate to treat, unfortunately, you're going to have to refer. But, access to patient records requires you to have SCR. If you don't have access to SCR, it's going to come down to your history taking skills. When you have a doctor who works in Harley Academy, or Harley Street, he doesn't always have access to your records. He's taking a thorough history. And if he really feels that this is unsafe, you can't treat, unfortunately. I hope that answers your question. Have you tried to access NHS funding for your clinic as a pioneer? Yes, I did speak with a clinical commissioning group. I spoke with a clinical commissioning group in 2018, before the community pharmacist referral scheme. And I explained to them this is going to happen in the future. And the reality is that what they said was that you're only one person. So had we have given you funding for your pharmacy, it's not something that we can do on a bigger scale. That's why it's important for us pharmacists, whether you work in a community pharmacy, whether you work in primary care, we're one team. We are one team. We have one same goal, and that is to help patients. Even you want to benefit financially, even I want to benefit financially. Everybody wants to benefit financially. So spot on, Samra. Yeah, it's correct. It's what you've been thinking for 2 years, and it's something that we need to now put into practice. And again, if you read the Royal Pharmaceutical document by the Royal Pharmaceutical Society, it mentioned exactly that. Since 1970, we've been thinking, but it's time to do something. So certainly, Samra, get in touch with me. I've left my number there. We can have a conversation, how you can put that into practice. But definitely setting up clinics is the way forward, and gathering data. If you're unsure about where the pharmacy profession is headed or where the NHS is heading, just read policy. Go back and read the NHS 5-year forward plan. Go back and read the health education workforce strategy. Go back and read the NHS 10-year plan. Go back and read the RPS document, and you'll find out exactly where it's headed. But yeah, certainly that is that. Right. When the best time to talk to you? Oh God, that's a good question. In theory, anytime, but if my wife was here, she'd probably get a bit peed off because I I do have a set curfew now, actually. In actual fact, what she says is I'm suffering with addiction to my social media. And the other day she was telling me that I need to kind of just block this out. So send me a message. We can have a conversation at any time. You know, it's no problem for me, and we can liaise to make sure it's good for you as well. I think we're done. So thank you very much for your time. Are you all happy for me to send you, because I think you will normally have to have access to the webinar, so we probably have your details. I just want to make sure that you're all happy for me to send you information over about the training program, and welcome to have a discussion. Thank you.